Hi, welcome to Health Healthcare. It's Wednesday, March 27th. And we have back in front of us today two of our most favorite people, like you're part of the committee from the Office of Healthcare Advocate. So we're going to spend some time in 2022, and they'll give you more information, but we passed a bill that I think started in here. It's an H bill, and about trying to align our hospitals with bad care, bad debt, and free care. And so we've asked Office of Healthcare Advocate to come back in and give us an update. So hopefully you'll remind us what we did and then give us an update. Great. Turn it over to you.
So good morning, Mike Fisher, Healthcare Advocates.
Emma Zales, also Healthcare Advocate.
And yes, don't mean to overstay our welcome. At some point, you're going to be like. So yeah, I think thank you for giving us an opportunity. It's actually been fun for me to turn back the clock a little bit and look at what we did and to come and it's really timely to do an update on this bill. So let me go to the next. Let's see where we at. Here's what we're going to try and do today, a little background, a little bit of a sort of primer on three terms: uncompensated care, bad debt, and free care. And we'll say more about it, but I'll just say generally, I know that if you had a hospital CFO in front of you, they would describe it more complicated than this. But in a really simplistic way, uncompensated care is made up of bad debt and free care. There's two different categories of uncompensated care. Let's do the next slide.
Okay.
And I think maybe just a little grounding. I'm going to do a little bit of the upfront slides, and then Emma's going to do the meat of the content. And yeah, there's a ton of information in this presentation, and we're going to skim through it. So when you look at national data, at least according to Kaiser, Vermont's not doing so hot on medical debt. We're one of the states with more medical debt. And I think they did a survey. And so exactly, 2019 through 21, our whole presentation today and our whole project is about medical debt in the hospital setting. Just a little level setting, about, I'm not sure if it's, I don't know if Julia knows, 38% of Vermont healthcare spending happens at Vermont hospitals. And so our whole discussion here is about the uncompensated care, the bills that people can't pay or don't pay at Vermont hospitals. There's a great deal of unpaid bills and dynamics of people not being able to pay their bills in the rest of the healthcare system that we honestly don't have as much insight into.
All right, I have a couple questions, Leslie and then Alan.
So I'm just wondering if you understand, and you may come to this later, what's structurally different between Vermont and Oregon or Hawaii?
Or like California.
Well, I think California is
5%.
huge, so, okay, let's see what's more equivalent to us.
Right, but
Yeah.
yes, and then I mean to
Yeah.
go off your question at all. But because California is so huge, I would have thought that their medical debt would be higher.
I actually don't know the answer to that. Do
I
you?
don't 100% know the answer. I do know California is on the leading edge of expanding Medicaid. So
Okay.
they eliminated the acid test for Medicaid for the age-blind and disabled. They have expanded coverage to a large swath of undocumented folks, so not just children and pregnant people. So that could play into it. But we have one or two other people on the health policy team who likely have some good article ideas. So I'll pick their brain later. And if I find a good one about state differences, I'll send it out.
And I didn't mean to go up Leslie's question.
No, no, that's fine.
I don't know what state you asked about.
It doesn't matter. What matters to me is what's structurally different and what can we learn from that and then move in that direction. So that's what I would hope for. Yeah.
Alan?
Yes, thank you, guys. The medical debt for the adults, is this because they don't have any insurance or their copay is too high? And what's some of the other reasons?
Yes.
Those could all play into it. And that map, I think, was significant medical debt, and I think it was measured at 250 above. It was 250, not 500, I believe. So Vermont clocked in around 12 point something percent of adults have significant medical debt.
I want to fix that.
Yeah, and this is a structural question in terms of past legislation nationally produced. Didn't Obamacare require folks to have insurance? Wasn't that part of
So-
the
Well,
plan?
Yes, originally, there was a requirement that that Americans have insurance and a penalty if they didn't. That
Yes.
penalty was not so popular and was
Okay.
attacked and officially, legally, there still is a requirement that Americans have insurance. The penalty is zero.
Okay, so somebody can choose not to have it and they just float out there and,
And FYI, Vermont had quite an involved process to consider whether we should, when the Trump administration zeroed out the penalty, we spent quite a bit of time. There was a work group to evaluate whether Vermont should have a penalty. At the end of the day,
you didn't, okay.
we couldn't land up.
So there are a number of people out there that just don't have insurance.
But let's recognize our uninsured numbers are very low. Our
this
real-
isn't just people that don't have insurance.
Yeah.
Let's be clear about
You could
that.
have a really large deductible, so you could have an insurance plan through the Affordable Care Act, but it has like an $8,000 deductible. or
Yeah,
something.
right.
You might not be able to afford
Right,
that.
right,
so-
okay. Just wanted to,
Yeah, context is good.
To that point, and you might know this off the top of your head, because I know you deal with that health insurance survey a lot. So we have very low uninsured compared to other states. How does our underinsured compare to other states? Because we have a huge underinsured.
So I don't know whether other states do I think we do a robust, the household health insurance surveys are a really good survey. And they have I think a good, stable definition of underinsured that we've used for a number of years. So we have some longitudinal data on it. I don't know whether other states have been doing a survey like that.
We do have-
so what is that definition, Mike, of underinsured?
You know-
Because I hear that a lot here and I mean, your insurance is what you want it to be.
I would have to dig it out to get it right.
Okay.
Because it's different at different incomes and it has a component about actual bills and a component about exposure. So let me get that.
Okay,
So
Wait, sorry. And then we really are gonna keep
Yeah,
going.
I just wanted to understand what the definition of significant medical debt is for a hospital. Is there like a number, like above a certain amount?
well, so in that survey,
I wasn't sure, maybe I missed it.
Oh, yeah, in the survey, I think it was 250, I can double check later,
yeah, that's a good.
dollars.
Dollars.
For an individual.
For an individual,
So if
200,
you owed more than that to a hospital, they can, or to providers, they
Huh.
consider that as you having significant medical debt. So they have
But-
to draw the line somewhere.
okay, I just was curious.
Yeah.
but I gotta push back on even that number. You know, we have a helpline. There are folks on the phone right now helping people with bills. And, you know, for one person, that $18 bill is huge for them. And for the next person, that $500 bill is a nuisance. So it has a context in the family.
Totally agree. I just wasn't sure what
Yeah.
number you were using.
Yeah.
I wanna, pull something from my brain.
Good luck.
I'm hoping.
Man, Lori,
Hoping someone can help me, but a couple of years ago, I'm just trying to put this in context. Because some people might be like, oh, $18, of course someone should be able to afford $18 or even $250 or whatever. But there was something that was put out in the news that a percentage of Americans, a very large percentage of Americans do not have, I think it was $400
Yes.
to cover an emergency
Yeah, that's right.
crisis. And that includes healthcare. Like people, I mean, I have health insurance. I have a huge deductible. I question every time someone in my family has to go to a doctor, I question it. And I can afford it, but I question it because it is not in the budget, right? So that's, this is a big deal for a lot of people across our country and Vermont.
Quick question on that. From the experience I've seen with a lot of young people I've coached it up, they elect not to have insurance.
Right.
It's a choice. They think they're invincible. They don't need insurance.
Yeah.
So then if they do go to the hospital, I'm sure they're paying $1 a month. And that's considered this debt, right?
So let me jump to people.
Well, okay, people.
Let me talk about people for a minute. So it must have been 21 when we did the survey. So we've been working on medical debt for a long, long time, Healthcare Advocates Office. This is long-term work that we've been doing. And so sort of in build up to what became Act 119, we did a medical debt storytelling project. This was pre-Emma. I just wanted to reference her because she's around the building. We hired a contractor, Meg Polite, between when she was at the Lieutenant Governor's office and the Alzheimer's Foundation. And so she worked for us for a little while doing a storytelling project. And the results of that, can I click this or should we? So that word cloud comes from the storytelling project. That's sort of, you have a program that pulls words out of all the responses. There we go.
There we go.
So we did a storytelling project and worked with Code for America is a sort of educational program that happens around America, and there's a Burlington office, Burlington Pod or something. I have a funny name for it that worked with us to put together this webpage so that we could take all these thousands of responses and put them together into a presentation. And so this is a webpage that we built with them. And in the presentation, that word cloud is a live link, so you can click on it and get to this page. So we're sitting in Washington County, so let's go to Washington County. And you see a story. This person put off dental care primarily. The costs are too high. Medical debt is a burden on our family. This person also did dental. But look at the next line. Worry, anxiety, anger for being questioned about money upon arrival for emergency care, embarrassment. FYI, these happen randomly. So this next person says, unwilling to seek medical attention because of the cost, lack of insurance. We are left to live in wonder and fear when testing cannot be completed. So I'm not going to read any more, but if you want, take some time, look at your own communities, and you'll see real Vermonters' voices about the impacts of medical debt. Now, you're going to hear people, or you will hear people who will characterize people who don't pay their bills as cheats, as freeloaders, as wealthy people who are hiding their assets. People will tell that story. And I'm sure there are people like that. And hey, if a hospital says to me, I know someone who's got a second home and they've got a lot of money and they're not paying their bill, I say, go after them. Not defending that person one bit. These voices, though, tell a very different story. It's the kind of story we hear on the helpline every day of people who are just desperate. They don't know what to do. And when you're desperate and you can't pay your bills and you're afraid of what a sickness will do, you don't get care. You put off care, you hope it'll get better on its own.
What I'm hearing in some of this wording too is people are not going into debt. They're not choosing to do something because they don't want to be irresponsible. I don't want debt.
Right.
I'm choosing to let my health go because I don't want that. You can't always control whether you get really sick and need help. That's the piece.
Right, and putting off care, maintenance care can lead to a bigger emergency down the line.
Yeah.
Yes.
No, I'm on here and I click Chittenden County and the very first one is somebody in paying 2.5 years to pay off $3,000 for a test their doctor ordered and their insurance company refused to pay it because it's prior approval. So, just a little item.
Hand it all back. Topper has a story.
I have a story, and it's very current. My son's in the hospital now, and that bill is gonna be in the tens of thousands of dollars. And he said to me before I left there yesterday, Dad, I have insurance, but it's not good. How the hell am I gonna pay it? And he's telling the people there, no, I don't need to go to the rehab place. The reason he's telling them that, because he can't afford it. He works every day, sometimes till 6 o'clock in the afternoon. So here's a kid, well, he's not a kid anymore. So I told him, I said, don't worry about the bills. That's the worst thing you can do. You gotta heal. If it takes me to take some of my retirement money to pay this bill, I'll pay it for you. Don't worry about that. Now, here's a kid that he's worked all his life. He just doesn't have the insurance that he needs to pay for this thing. We're hoping that USA Hockey has some kind of a blanket insurance that might help out. But that's the kind of person who is getting hammered. And I think everybody at this table knows that the biggest amount of bankruptcy is because of this. And I don't want to see him go bankrupt over this.
No, and you don't want him to worry while he's trying to do it.
No, that's the worst thing that can happen to him.
I'd like to move on.
Okay, but I have a story just to add to his. It's like
Okay, can
three
we?
sentences. It's like my son, who did not have insurance at 28, was hours away from dying because he had diabetes and didn't have insurance and would not go to the hospital and was sick for 6 months, ended up with hundreds of thousands of dollars of bills because he ends up in the ICU. And that's also driving huge problems for a young person.
And just because it hasn't been said out loud, put it in the context of mental health. People, people often, they don't want to go, they don't want to face it. And the fear of copays and expenses lead a lot of Vermonters, Americans to say, maybe it'll get better. I hope my anxiety will get better on its own. If you believe the treatment works, I believe treatment works.
I'll just drink more water, I'll be fine.
So, all right,
Let's keep going.
let's keep going. How do we get back to it? All right. Again, uncompensated care is made up of bad debt and free care. Simple, trying to be simple here. So in 2022, the last year that we have actual numbers in Vermont hospitals, they reported to the Green Mountain Care Board a little bit over $100 million in bad debt and a little bit under $40 million in free care. A little bit about the terms. So free care is the hospital has done an assessment on the person, they filled in an application, they've applied for it, and the hospital said, you don't owe us this money. We are giving you the care. We are recognized, right? I don't want to use the word
Oh,
writing.
okay.
We're recognizing that you're not going to pay. It's, they call it charity care or they call it free care. So the person doesn't owe the debt. Bad debt is actually an accounting term. It means it doesn't make sense for us to keep this revenue on our budget anymore because we're not expecting to get paid. So after some amount of time, consumer unpaid bills gets recognized as bad debt. And they take it off of their revenue, their expected revenue sheet. It doesn't mean they still don't chase the money. They might hire a collection agency. They may still do activities to try and get the person to pay it. And it's certainly I'll just say, from the hospital perspective, a bill that's not going to get paid because they've said, oh, you can't pay it, and a bill that's not going to get paid because it just doesn't get paid, looks the same. Uncompensated care is uncompensated care. They're not getting paid. I recognize hospitals do chase after bad debt. We understand they get paid pennies on the dollar. We also know that there's some small revenue for uncompensated Medicare claims, but understand it to be very small. So from the hospital perspective, unpaid bills are unpaid bills. From the consumer perspective, none of those people in that earlier webpage who get free care are saying, oh my God, I don't know what I'm going to do with this bill. They don't have the bill anymore. All of those bills, all those, the crisis around unpaid medical bills are in the category of bad debt. So you've known me for a little while. I'm always looking for money. I'm always looking for money for consumers. And so we have always been convinced that there's a good bit of bills in that bad debt category that should be recognized as free care. That we can agree people aren't going to be able to pay. And so that's sort of the major effort of that we've been after is, sort of like, what if we could make bad debt and free care across the hospital system one-to-one? What if, and the math right here for 2022 is if magically bad debt and free care were equal in size, it would save Vermonters $32 million in medical debt. And if my theory is right, and it doesn't make much of a difference, if we could do that without increasing uncompensated care, it's $32 million of relief for Vermonters that nobody has to pay for. That doesn't cost anybody anymore. It's already unpaid. So that's sort of the theory behind. And so, any questions about that?
Yeah, me too.
Yeah.
I don't get where you're driving at here, Mike, because bad debt and free care are the same thing, really. As far as I can see, you're
From whose
forgiven the
perspective?
debt, and that's free care, and the others that you're owed. So really, it's all bad debt. It's just some you're excused, correct?
From the hospital's perspective, you're right.
So how can that be? And I understand it, but how can I explain it again
Yeah.
so I can
So-
understand how we save $32 million?
Put it,
I don't get that.
so let's say I owe $10,000
Yeah,
and I'm in that bad debt category.
yeah,
I've gotten a bill. I can't pay it. I don't know what the bleep to do about it. I'm panicked about it. So, what do you expect someone in that position to do? You expect them not to get care. You expect them to have a great deal of anxiety about it. Maybe they attempt to pay it and they do a payment plan, but
Yeah.
they don't know how they're going to put food on the table. And so, because we are talking about low-income people here, when we get to what we've actually done. So if I'm in the bad debt category, I'm living in stress and fear and panic about it. If I'm in the free care category, from the consumer's perspective, there's a world of difference. The consumer who's been given free care is saying, oh, thank you. I don't have to be panicked about the bill I have. Now, they may be panicked about getting more bills, but
now does the free care carry forward? So you've got that free care, you get more and more and more. You're always on free care, or how does that work?
Yeah, so we'll switch into the Act 119 portion soon, but typically hospitals will say, you know, if you apply for free care or discounted care, they'll say like, you know, it goes for 6 months or a year. But you know, if your income changes, you need to report that and we'll refund you.
But I think we need to be clear, right? We're saying free care for the individual,
Yeah.
right?
Consumer, the
The
Vermonter.
consumer does not have the money to pay for the healthcare they need, right? So that's one entity.
Mhm.
But it's not like the money is just magically disappearing. It is the hospitals, it is still within their accounting, right? And at the end of the day, we all pay for it.
Absolutely.
So, because the hospitals come in with a budget to the Green Mountain Care Board, and uncompensated care is a piece of it.
Mhm.
And then commercial insurance rates are, you know, I'm making it very, very simple. And yes, you're probably going to get to this, but so I just want to be clear. Hopefully
Well,
that
you're
answers your
right.
question.
I'm trying to understand how we save money if we make people give them more free care.
So we are helping the people who cannot afford the care.
I understand that, but how does that save money for the system?
Well, it relieves Vermonters of the pressure. But you're right. I think it's an important point. All of this goes to the bottom line of the hospitals and hospitals have to set their rates, including the uncompensated.
And I'm not saying it's wrong. I'm not
Right. No,
making
we're
a
just trying to
judgment.
understand it, right?
I just trying to because you mentioned you saved $32 million by,
Yeah, if we could.
how do you save that money though?
Well, maybe I said it wrong. If we could have a 1-to-1 ratio of free care to bad debt, we would relieve $32 million worth of medical debt.
For a consumer,
For consumers.
consumers.
Okay,
Not
you
for the
relieve the
hospitals.
consumer of
Yes.
$32 million worth of debt. All right, different thing.
Yeah.
All right, got it.
That help,
Got it.
Leslie and then Daisy, and
I'm
we
still-
really need to get through this.
You're never gonna get through this.
I'm still on this slide, and I'm really with you, Art, I'm trying to understand this because the total is like 140 million, right? Of if you add up bad debt and free care, the ratio is what it is. You want to go to a 1-to-1 ratio, and I'm not getting how it saves money. So I'm still.
So let's
Let's
hold
not-
that
that's,
question
Let's
as
persist.
we keep going, but wait, hold on, Daisy, that's good, what your question is.
So I want to focus on the patient experience, and I think it's important that it saves us, the patients, the pressure of having to respond to a bill or groceries. How does that experience look different when you're getting free care versus getting a bill? Is it just on your EOB or whatever? Is it just zeroed out or on your, can you walk us through what that looks like for a patient's experience?
So if you apply as a patient for financial assistance and you're approved, then they would reduce your bill. So if you were, you were approved for a 100% discount, they would bring your bill down to $0. If they approved you for a 40% discount, they would cut your bill down. And so I think what Mike was trying to say in terms of the savings to consumers, like the hospitals, it's all uncompensated care. Like the hospital, through Act 119, the hospitals shouldn't be any better or worse. But the consumer, the person who might go to debt collections, might, have this follow them for the rest of their life, can be made a lot better.
So
This relief.
in order for a patient who can't pay, they need to know about the ability to appeal and then apply,
Yeah.
and then it shifts into the free care category.
Exactly.
Okay, got it. Thank you.
So this relationship between free care and bad debt, something we've been focused on for a while, and I've been asking hospital executives in budget hearings for a while about the difference, about what it means to them, and about why it is there's so much variation across the system. And I'll get to that in a minute, but just sort of like, how are we doing on this relationship? So for every $1 of free care, how many dollars of bad debt have happened across the Vermont hospital system over the years is what this chart shows. And so we're not talking about the amount of uncompensated care. We're talking about the proportion of it that is given away as free care. And so you see you see what you see on that line. It is getting worse, recently, particularly.
Sorry, Mike, Brian did have a question, and then we're stopping questions.
Well, it was just a point, like that. Research shows, and I don't know if you're gonna show this in your slideshow, and if not, we can get witnesses to prove this, but research in public health shows that financial stress is a driver in a negative way on health outcomes. So when people are under financial stress, their health is worse. And then, and the other piece is that debt could be a barrier to care. So if a person's already accumulating debt because they can't afford their care and then they avoid care, their health issues are going to get worse. And then when they go back, it's going to cost more and they can't afford it anyway. So then the system is paying more for them anyway. So having bad debt as a barrier to access to healthcare costs everybody more. And it leads to negative health outcomes, which costs everybody more. I think I just want to make that point. And maybe you're going to illustrate it more. And if not, maybe we can look into it. Sorry.
I've addressed that a little bit earlier, but those are important points. Okay, so rule number 1 should be you never put a slide in front of a committee that has too many numbers.
We're used to this one.
So this is way more data than I'm going to expect you to look at. But my guys, Eric Schulteis is supposed to be with us at some point today. They like data. Looking at 1 year or one hospital doesn't make sense. We really need to look at trends across time. So let me just do a number or two. So look at the UVMMC line for 2022. The way you read that is for every dollar of free care, they had $2.02. Oh, look, I have them. For every dollar of free care, they had $2.02 of bad debt. And just to show you the variation, go down to the bottom. Brattleboro here shows in 2022, for every dollar of free care, $5.11 of uncompensated of bad debt. So there's a lot of variation. And so we've been asking, so I've got 2 theories about why there's variation. One of them is one hospital has a more generous free care policy than the other hospital. That would certainly lead to a difference. Maybe I'll just stop on that one. The whole goal of Act 119 was to normalize for that. And so to create a statewide minimum standard. And I know there's questions, but I'm going to push that for a second.
If you can hold your questions, that would be great, because there's a lot here that we need to get to.
So let me get rid of all the numbers. Let me just pause and say was it in 2022, Mari Cortez introduced the bill that became Act 119, and we recognize that.
Nothing.
And it was we were in the context of COVID, and it was a complicated year in house healthcare. And the chair at the time, Bill Lippert, sent the Hospital Association and the Healthcare Advocate out to work on it. And Devin and us worked and came forward with what became Act 119. So I want to sort of, we came back before the committee with a product that was finished. The committee accepted that work and it became law. Part of the agreement, Maria, you have your hand.
I was going to say, you just
stretching.
Okay. Sorry. It's like she's like, really? Yeah.
Part of what we agreed to was to postpone implementation for a full 2.5 years. So Act 119 was passed in 2022, but it's going into effect finally this July. Okay. I think that's what I just covered.
Yeah.
So I think we're going to hand it over to Emma.
Okay.
How much time do we have?
Till it's 10:25.
We got this. All right, so Act 119 fixed a lot of the differences in financial assistance policies across hospitals. So it looked at the content and application forms, the income eligibility limits, resource limits, regions. Different hospitals would allow for financial assistance for people based on the town they lived in or based on they live in the entire state. Different standards like that. How to count income, what income counts, that type of thing. So Act 119 really moved all hospitals in Vermont towards a more standard practice.
And we should say 15 hospitals, we are including Brattleboro Retreat.
Yeah.
Oh, okay.
Yes. All right, so we're going to talk about some of the general requirements of Act 119, starting with income eligibility. So there are two main discount categories, which we're calling free care. That is for folks who have income at or below 250% of the federal poverty level. If they applied, they could be eligible for a 100% discount or free care. There's low cost care, and that would be for folks who have income between 251% of the federal poverty level to 400% of the federal poverty level. And Act 119 requires that hospitals give a minimum discount of 40%. To that population who applies. They could, of course, give a higher discount if they want to. Some hospitals do give higher discounts at this point. So this just sets minimum, sort of a floor for all hospitals that they should meet. So on the left-hand side, there's a table with FPLs and how that translates into income amounts, just for context. And then on the right-hand side in the green box, you can see sort of a snapshot of the current landscape. So currently 5 out of 15 hospitals meet the free care requirement in Act 119. That means 10 hospitals need to up their game a little bit, and 7 out of 15 hospitals meet or exceed the low cost care requirement. They already get discounts that meet that minimum standard or exceed it.
Let me jump in and say all nonprofit hospitals, therefore all Vermont hospitals, are required to have a free care policy, required by the federal government. That's part of their nonprofit status. And so this was not like a groundbreaking, like, oh my God, we're going to have to do something we haven't had to do before. This was, the goal was to be an adjustment and to find a moderate place.
Never mind.
Art and then Alyssa.
I'm fine. I have one for later, just to
Okay.
put me in the
If that's
queue.
so, how are any hospitals not doing it? I mean, I don't get the 5 out of 15. What do you have to do to
This was
do it?
before.
Huh?
This was before the act was implemented.
Oh, before the act.
Yeah,
was
Sorry,
implemented.
yeah, and that was on a previous slide, but I don't
All right,
think we
come on.
verbalized
All
it.
right,
No,
all right.
that's good. That's a good catch. The
Gotcha.
implementation date
Too
is
much
July
info.
1st. It's
Right.
this.
First off.
No, that was a great catch. Art.
This year.
Okay, great.
Yes.
Yes.
This is the history of where we were.
Yes, yeah. So policies will be shifting.
All right, so all of them are going to be part of this.
All of them will be part of it. All of them will need to meet these minimum requirements. But like Mike said, all of them have financial
Hey,
assistance.
does somebody have to apply to be in on this, or does it just happen?
Yes, you have to apply for financial
All right.
assistance. Yeah.
Okay.
Yeah.
Okay, let's keep going.
All right, so if your income is over 400% FPL, there is a safety net that was built into the law. There's catastrophic assistance. So if your income is at or below 600% of the federal poverty levels, and your total medical bills exceed 20% of your household income, then the hospital has to reduce your bill to 20% of your household income. There's an example here. We've got Shelley, spouse and child. Household income is $129,000. That's 500% FPL. So too much money to qualify for free care or the discounted care. But Shelley was in a coverage gap. They had an emergency. Now they have this huge bill, $37,000. That is 28.7% of their household income. And the hospital therefore needs to reduce it to 20% of their income, which is $25,820. So in this, in this example, Shelley could apply for this help.
Alyssa and then Art.
I should know this and I don't. Do all hospitals or any hospitals have a self-pay price? which is different than their real price or the
Yes. It's a topic of much consternation. It's a little
So I think you're getting at sort of discount from what?
Yeah,
So a little bit of that is covered actually in,
Yes, I kind of skipped right over that. So if you have insurance, then the discount's off the insured amount. If you don't have insurance, I think it's the AGB, which stands for.
generally billed.
Thank
is
you.
Commercial payment.
So many acronyms. Yes.
Are all hospitals required to have some sort of payment plan? To offer something so that, monthly you get,
I don't know if they're required to, I think they do.
They do, most do. Yeah.
they do.
Hospitals do, but the IRS
Eric Schultz.
regulates.
Wait, hold on.
Sorry, I
Eric,
just jumped in.
Hold on, Eric. Can you
Sorry.
introduce yourself, please, for the record?
But for the record, my name is Eric Schulteis. I'm a staff attorney with the Office of the Healthcare Advocate. To answer your question, which is a very good one, most hospitals or all hospitals do have some type of payment plan. What's currently exists regulating these type of things is these IRS regulations, and those are exceedingly vague and open for interpretation. So, and also the IRS really doesn't audit hospitals for compliance. Thank you.
Thank you.
That's Eric Schulteis, member of our team.
The voice. We didn't see you come in, so. Right.
All right, I'm gonna keep us moving. Resource eligibility. So, Act 119 says that hospitals can have a resource test. And currently some hospitals do, some hospitals don't. But Act 119 says if you do have a resource test, there are certain requirements. Your resource test can only apply to liquid assets. And it shall not include your primary home or your retirement accounts or pension plans. The hospital also cannot consider liquid assets that are less than the dollar amount that's equal to 400% FPL for your household size. What on earth does that mean? Here's the example. If your household size, if you had 4 people in your household, then the liquid asset limit would be 400% FPL for household size of 4, which is about $124,000. So if you had savings less than that, you can hold on to them. If you had savings more than that, then the hospital is going to say, sorry, you do not qualify for financial assistance. You really need to pay this bill.
Savings and not retirement.
Savings, yep. So they're looking at like checking savings accounts, that type of liquid assets.
What about savings? What about savings accounts? Like, I know for tax purposes, a person can keep a certain amount in reserve to repair their home. Would that be subject to this?
That is a very specific question.
I'm sorry.
No, that's okay. I will take that back.
It's a real thing for like working people who might be struggling to keep their home. They have to give up the reserve that they need to repair,
Yeah,
if something goes wrong.
that is a great question. I don't know how to answer that.
We can look into it.
Yes, that's a good
Moving
one. Moving along. Okay, so there's also requirements around residency. So hospitals can require an applicant to be a Vermont resident, but for the first time, Act 119 is setting a standard definition of what that means. And Vermont resident must include students, people who are employed in Vermont, undocumented immigrants, people living in Vermont, but who lack stable housing. Historically, some hospitals, allowed financial assistance for some of these populations and not others, and it all depends on what hospital you were at. So this really levels the playing field and says, this is the definition that everyone's going to abide by. Hospitals also cannot impose a durational residency requirement. So they can't say, you must have lived here for 6 months. I'm sorry, you just moved here, or I'm sorry, X, Y, or Z. There's no duration requirement. You either are a resident or you're not. It sets a standard set of classes in terms of protection from discrimination and the application of the financial assistance program. Not going to read it all, but it's there. And And there are, so Act 119 has requirements around public education and outreach. So the financial assistance program and policy need to be easily accessible on the website and through the patient portal. Paper copies upon request need to be easily available, free of charge, by mail, in person. Copies need to be in patient reception, admissions areas, billing locations, all the places that are frequented by patients in the hospital or provider's office. Oral and written translations need to be provided upon request, and they need to have conspicuous display or notice of the financial assistance policy in various areas of the hospital. So when you go to doctor's appointments after July 1st, you can be like a secret shopper and like check out what you see.
Hospital, not a primary care.
Yes, yeah, only if a primary care was attached to a part of the hospital system, which some do. So yeah, but not a private. Good question. Additional requirements. Community notification or outreach. Hospitals need to reach out to the community in a manner reasonably calculated to reach the members of the community who are most likely to need financial assistance, including members who are non-native English speakers. So they have to develop a plan that is community specific. And there are direct notification requirements, paper copy of the financial assistance policy at the patient's first visit, or if you're hospitalized during intake and discharge. There needs to be conspicuous notice on billing statements, and medical debt collections or written all need to reference the existence of financial assistance. It exists, you can apply. This is the plain language summary slide, which is near and dear to my heart. I love plain language. This is the big piece of educational sort of outreach material that would help people learn about the policy. Because the policies, of course, are written with a lot of technical jargon and legalese, but we need to sort of bring it to a level that everyone can understand. So the IRS requires a plain language summary of nonprofit hospitals' financial assistance policies. There aren't a lot of rules around that historically, which has been really frustrating. And so this sets some additional requirements, saying you need to develop one and submit it to the Green Mountain Care Board for review. So hospitals will be doing that in the upcoming budget sessions. And this is an image of a template that we created for folks, for hospitals to use if they'd like. It's at the 8th grade reading level.
And currently, I mean, we found as we've looked at existing ones, have a
30th grade reading level. I'm not even sure what that is, but yes, they are definitely incomprehensible, many of them. So there's a lot of good work that can happen there. So before seeking payment, hospitals need to determine if a patient has insurance. If they want to apply for insurance, a hospital needs to help them apply for insurance. That's something that I think most hospitals already do, but those requirements are solidified here, and they need to offer to help people apply for financial assistance as well.
If, I don't know how to phrase this, if you're getting free care, why would anyone go get insurance? I mean, can you say you must get insurance?
So remember how much care is delivered outside of the hospital system.
Mm-hmm.
So if you don't have insurance, you know, and you go to a private doc and you can't pay, then you're out of luck. If you need care outside of Vermont, you're subject to those rules.
Yeah. But the big kahuna, the big payments are usually in a hospital.
Mm-hmm.
It just occurred to me, you can't, you're asking, not telling someone to get insurance. Okay.
Mm-hmm.
Just want to clarify.
Would another benefit be that if a person is eligible for Medicaid, it might pay the hospital the debt? Like, in other words, if a person, is that a possible benefit? Like, a person may not realize they're eligible, or they might have been booted and like out of the system or whatever it was called, unwinded. But they're actually still eligible. Like, is that one of the potential benefits, is that they might have like a low, they might qualify for like a reflective silver plan or some other kind of, I mean,
Oh, yeah. I mean, hospitals, they have assisters, navigators on staff, and they help people figure out like what could you be eligible for. With Medicaid, you can apply for 90 days retroactive. So, you know, if you were really sick and you came into the ER last month and your income would have qualified, but you didn't know about Medicaid or you got booted off a few months ago, they'll help you apply. So yeah, it's definitely geared towards, you know, those positions are geared towards getting you coverage. And financial assistance is typically geared towards helping you with things that aren't covered if you can't afford to pay.
And since Medicaid was mentioned, let's just recognize there's no very small copays in the world of Medicaid. You know, so this bad debt that we're talking about is for people who are above Medicaid levels. We're uninsured, we're
Okay.
above Medicaid levels.
so if they qualified for Medicaid, it would just take care of the bad debt.
Take care of their,
Yeah, it wouldn't be bad debt anymore. They would just cover the care, the unpaid care, and then the hospital doesn't take a loss either because they're taking advantage of a benefit that the person didn't realize they had.
Although the hospital is taking a little bit of a loss because they're not getting paid the proper reimbursement rates for the care they're providing when someone's on medication.
Fair. That's another issue we'll have to fix.
Right. Mari, and then Art.
Are there situations in Vermont, this is a broader picture, where hospitals are able to get benefit from private equity purchasing bad debt? Does that situation happen in Vermont?
so I think we have,
You're talking about bad debt in a little, I mean, about that in a little bit.
right,
You can't sell.
I can't sell.
Yeah, that was in the bill.
Yeah,
That's coming up.
I mean, I see Eric Schulteis popping on the screen. I'm gonna turn that one over to him and also turn it to the medical debt slide. Eric, if you want to speak to this question, you can also pass if you don't want to.
There it is.
I do. So it's not, no hospital currently has a practice of selling medical bad debt. It is explicitly prohibited, that type of sale, in Act 119. If it was to occur, I think perhaps a good indication is that a national organization around or representing organizations that buy medical debt actively worked against the legislation or tried to. So it is not a practice that currently occurs in Vermont. It is prohibited under Act 119. And at least depending how you interpret it, medical debt buyers were interested in ensuring that they could do it in the future in Vermont.
Thank you.
Does that answer your question?
I do want to make a distinction though. Hospitals don't today and after July 1st can't sell medical debt, but they can employ a debt collector to help them collect debt.
Yeah, those are different.
Those are at different levels. To the consumer, it might not look any different. I've got this debt collector coming after money I owe the hospital. The consumer might not appreciate or understand that the hospital still owns the debt.
Yeah.
But they're still dealing with the debt collector.
And I apologize if Eric just said this. Can a hospital, if they're not selling the bad debt, it's not going to a collection. No, it can still go to a collection agency, but the hospital's owning it. So a collection agency could still report it onto someone's credit report.
I believe so.
Okay. Art?
I had another question, but I'll ask a basic one. Are you going to cover who's paying for all this bad debt in the end here as we go through the thing? Because this affects the system somehow.
Yeah, we're not going back to it. That was, it should have been stated clear in the very beginning, maybe. That slide that showed a little bit, close to $100 million in bad debt and close to $40 million in free care. So $140 million in uncompensated care. Lori said it earlier, it's really true, but those unpaid bills go to the bottom line of hospitals today,
Okay,
before the implementation of this and after the implementation.
This isn't new, right? This bad debt, free care, like you saw the chart, we've had it, it's growing.
Yeah.
This is just, now we're trying to work with it, but yes.
Yeah, it's consumer protection, right? And essentially. Yeah.
Right, the idea is the hospital won't be any better off or worse off. Still uncompensated care, still the same amount, but for the consumer, they make a really big difference for the individual.
But I just wanted to find out
Yeah.
where this appears, and it appears in the bottom line of the hospital
We pay for it.
right now, no matter what.
We pay for it in out-of-pocket costs and in rates and in insurance rates.
Rates that the hospitals sets.
Rates.
Does it affect premiums of insurance companies?
Absolutely.
I'm trying to mash
It
it
is-
through
We
my
are
head.
all paying for this
Okay.
in our premiums.
Right.
And taxes,
Like,
taxes and fees.
They're part of the cost of care.
Okay.
All right, let's see. Complaints, so, Act 119 does require hospitals to have an appeal process. So if somebody is denied financial assistance, they can appeal to a hospital, and ultimately, if they have a concern, a complaint that rises above that level, they can bring it to the Vermont Attorney General's office. So our office has been in touch with the AG to help them sort of, get up to speed and know that this is coming and they might have some complaints in the future. And so we've been in talks with them, and they're working on it. And I guess that's a good segue into just the work that we've been doing. So we have been doing a 1-year lead up starting in July 2023.
And when we say we,
Oh, no. It's been a group effort. With lots of help from the rest of the team. But so the Healthcare Advocates Office has been trying to get hospitals ready for this change. As we said before, all hospitals have financial assistance policies, but they need to, each hospital will need to adjust theirs in different ways to make sure that they're meeting the requirements of this act. So we sent out a letter introducing Act 119 back in July 2023, saying we're going to roll out resources and information to help you every couple of months, all the way up. So we have sent them a model financial assistance template that they could use and adjust, copy paste language, to help edit their own, to make it easy for them. We have sent them a requirements checklist in plain language because, reading the statute can be a little murky. We sent them a plain language summary template, the 8th grade reading level template, to say, hey, if you've got a really complicated one now and you don't have the time and resources to redo your own, this one complies. You can plug your hospital information into it. You can put your logo at the top, you can use this, and this will communicate your policy. So we have tried our best to support hospitals along the way. Our last delivery of resources will be next month. Our outreach coordinator, Alicia, is going to design some poster templates and social media graphics that hospitals can use, for free. So all of this leading up to July 1st implementation.
and I recognize this is new ground for the Healthcare Advocates Office. I don't think we have ever been so involved in sort of technical assistance for other entities to comply with the law. And I think it's important and really good that we've been able to.
We want them to succeed.
And I think from what I've heard, so hopefully you can verify this, the hospitals have been collaborating as well.
So it gives me the opportunity to say, hey, never approach anything like this with a sense of like, gotcha, like I want to catch somebody and not doing something. Like we want hospitals to be successful in this. We're going to give them every bit of support that we're able to do to help them do it. Some hospitals have engaged a lot with us. Some hospitals not so much. And so part of the, it's important for me to say publicly, we are going to be asking about it, in the next, in August, in the hospital budget season, we will have an opportunity, the Healthcare Advocates Office will have an opportunity to talk to each hospital's publicly, to each hospital's leadership. And to the extent that hospitals haven't stood up their free care policies and are not in compliance with this, heads up, we're going to be asking about it. So, I want to do fair disclosure here. I think it's important that healthcare advocates should be really predictable. I think we are very predictable.
Leslie, wait, I think we're almost done. Let's just finish this up.
We're
Okay.
done.
Oh, yes.
Thank you, Leslie.
I was about to check too.
It sounds really great with hospitals. I'm thinking about the consumer side of things. How do they find out about this and or the complaint process or any of it?
Yeah. Yeah, well, part of the work with hospitals and the plain language summary and like the poster templates will be geared towards trying to help hospitals make sure that they're putting the word out there. But we are also probably going to be developing some consumer facing materials, possibly a web page, that type of thing. So we'll probably be moving into those discussions over the next couple of months with our team. We've been really focused on helping hospitals gear up as they've got this deadline. But we have a very long task list and there's a whole consumer section there. So we'll be diving into that soon.
I'm just looking at your plain language summary and you don't mention complaints, or.
Yeah, there is a second page to that. And I'm happy to send out I'll send you all the full resource template. That was just a screenshot of the front, but on the back, it does talk about complaints, non-discrimination, different ways to apply, that type of stuff.
Yeah, because I'm also thinking about Front Porch Forum, which is in my area a
Totally.
really good way to get stuff.
Yeah.
Thank you.
Okay.
So I know that I was part of this and I should know, I should remember, but did we ask you to do this work in Act 119 or are you just doing this because it's your mission? And either way, are you properly funded to do this work?
It is the latter. We did not get tasked specifically with
That's what I
it.
thought, yeah.
But we are trying to improve, but it is our general mandate to improve the system for Vermonters, and we saw this as our.
I appreciate it because if we didn't ask you to do it, I just appreciate the initiative that you're doing it. And I appreciate that the hospitals also, for what it's worth, I know there's representatives of the hospitals here. I appreciate that they are being proactive with you. And I think we also have to acknowledge that that's work, time and labor that we need to take into account when funding the healthcare advocates office. So that's all. Thanks.
Art?
Yeah, is it possible the plan when implemented will add more Reading?
I guess let me back, I suppose so. It's something,
There's a lot of different numbers and indices and things like that in here.
Yeah.
Which sound, as a consumer, sound good. But I'm wondering, because we do look at the viability of hospitals, and if it adds a lot of red ink,
so
then I don't know.
two things. One of them is there's more than 50 other moving pieces that could or may add red ink.
Well, absolutely. No question.
So that's one thing. And then the other thing is, I guess I want to say again, this was an agreement between the Advocates Office and the Hospital Association.
Yeah.
And, the goal was to be careful that we found a place that would be better for consumers and not. All hospitals already had free care policies. Many of them are more generous than this
Right.
already.
But when you raise the income like you have, and then put in the indices, and now folks that do have means can cut their bills, I just worry that or wonder if that will.
I'll just say, for the largest Vermont hospital, we have not raised the income, the eligibility. Am I right in that?
Yeah, I would say this treads a pretty middle line. So a lot of hospitals actually have more generous policies
Oh.
than this minimum floor.
Okay.
So it's possible you could see hospitals adjust to some extent in the coming years if they started feeling
Adjust
like, whoa,
down.
right, they
Yeah.
could potentially adjust
All
down if necessary.
Fair enough.
For some hospitals, they'll need to bump up their policy a little bit, but it's not a huge,
It's not a huge difference.
it's not a huge difference, and it's really to sort of ensure that Vermonters, no matter where you live, if you live in a big city, if you live in a town, 2 hours away from a big hospital and you just have your small hospital, that you have sort of an equality of
Even the
access.
percentages that you pay are similar in these hospital policies, or is that a variable?
It's a rate setting is a whole
Just
different.
bring it up.
Yeah.
Don't have to tell me.
Like, I hear rumors, I guess that's what I'll label it, that hospitals, talking about global budgets. How would a global budget impact what we're talking about right now?
I don't think this would have any impact. I think we should find a time, I think there will be a time, there should be a real in-depth conversation about global budgets and what it may mean for hospitals. And what it may mean, I think your question, what it might mean for consumers is a really important one. But I don't think this in and of itself has any impact on it.
Should we take the discussion screen down so people can see
Yeah,
the discussion, not to.
There's more stuff.
Anyone else have questions, comments, Leslie?
Well, actually, I'm concentrating on what you just said. So when the global budget is established actuarially, don't you think this would be included in that calculus for a hospital?
I really don't think so. I think the global budget, first off, global budget is about how much Medicare is going to pay. I should stop myself. This thing is huge and really complicated, and I've probably spent hundreds of hours in technical work groups about it. Global budgets are about how payers, first Medicare, are going to pay hospitals. This is about the patient share. It's a bit of a different category.
But it does affect what the consumer will pay.
But I don't think global budgets is at all about the relationship of how much the payer pays versus the consumer pays.
I get it.
It's just about how the payer, and it's just about.
Being devil's advocate here.
Which I always say the devil has enough advocates.
No kidding.
On this bill that's supposed to take effect, you mentioned that no liquid assets shall not include primary homes, 401ks. I have an issue with maybe somebody's got $1 million in their 401k and IRAs being eligible to be on a payment plan or a discounted care. So I think there's enough people out there that really are truly in need of that without taking.
Yeah.
So I don't know. I just don't understand how that got there, but.
Yeah.
I think the
I
concept,
might be able to throw something on that one.
Yeah.
If you got $1 million in your bank account, you probably are not going to be eligible.
Didn't say that here.
401k.
Or 401k.
People and myself included saved all our lives, 401ks, IRAs and everything. For this thing, when I get older, I'm not gonna be so healthy. Look at it. All right, so that's what I saved it for.
because I predicted this question or question I get earlier is why I was talking about the sort of this concept of the cheat. Of the person who's gaming the system, who's figuring out a way to not pay their bills. I know there are people like that.
Like corporations.
Okay.
Right now, I'm talking about. The goal of that was to say to the person who has a nest egg put away so that they can live through their retirement, that we don't need to impoverish them. We don't want to say, you've got a couple $100,000 as you're stepping into retirement, and it's probably not enough to make it that we're going to impoverish them. We're going to take away their ability to have something of a dignified retirement as they reach a stage where they need to depend. I mean, that was the goal of it.
Yeah, I guess I'll just add, I think there's always an edge case, but a lot of folks with $1 million would probably buy a platinum plan. They've got a good insurance plan usually. Or if I had $1 million, I certainly would have a very nice insurance plan that didn't have a high
Gamblers
copay.
out there, you think.
This is a little bit of a philosophy thing that we shouldn't go into too much, but the effort that you have to do to stop the gamers prevents a lot of people who really deserve it.
Yeah.
Getting it.
Exactly.
And what's the return on investment? I think that's
Yeah.
you're gonna have to ask yourselves that question anytime you're giving a benefit.
Listen, I just wanted to make a comment because we're sort of going back around to where we started with the whole conversation. I did medical collections for 30 years of my life. I have heard it all. I've seen it all. And there's always going to be a contingent of people like, you were asking, are they people like this or are they people? It covers the gamut. It's a 19-year-old who doesn't have insurance and then gets in a mountain bike accident and because they think they're invincible. It's, the person who literally cannot get by. It's the person who had a horrific accident and ends up in the hospital and is now facing down tens of thousands of dollars of debt. And there's no way they can pay it. And then every once in a while, very, very rare, there's just somebody who comes along who just doesn't think they should pay their bill, but it's everybody. So I just caution everyone not to have in your mind about who we're talking about. We're talking about everybody. Yeah, that's all.
Let me also add while we're just having discussions, there's other activities to do to reduce uncompensated care. Activities like H721, which will bring into, coverage for a population of people who nobody can argue can afford to pay their bills. And so, sort of right sizing the difference, how hospitals manage bad debt and free care is a whole category of work. Also reducing, appropriately covering people is a whole nother category of work that this committee's been involved in that.
And I just,
Well, I recognize it all impacts each other.
it's all connected. And I just want to remind people, when we did take testimony in 721, everyone came to the table in support of the Medicare Savings Program. And one of the reasons was this, in order to draw down the federal funds to be able to cover folks where we can then reduce some of the uncompensated care at the hospitals. Brian, and then I think we're going to be done.
Last question. It's not even that good.
It depends.
It's not even that, it's not that exciting either. But just to this point, is there a way for us to track that? Because it would be interesting to see as the impact of 721 plays out. It would be interesting to see if free care and bad debt drops, because that's a population of people who can't afford care. So I'm just curious if that's tracked or somehow we can.
You can count on the healthcare advocate.
You will be
continuing to watch those numbers and working as hard as we can to make sure those numbers are accurate and reported in a consistent way. It's a major project.
The wizard came out behind the curtain.
Yeah. Comment on that?
Sure. I mean, so Representative Chena, there are ways. There's what's reported to the board. There's IRS 990. There's a Medicare cost report. The 990. Well, all of those things lag. So the board reported would be actuals. Those lag by 2 years or a year, and the 990 lags by a year, and it's somewhat dependent on when the IRS releases information. So I think we would expect, or the working hypothesis is that we'll see a shift from bad debt over to free care, which in terms of how it looks in the hospital's books, it's indifferent which it's booked as. They're both booked as a deduction, but one clearly benefits consumers and one clearly hurts consumers. So we will be tracking those indicators both to see if the MSP bill passes, how that plays out, and when this bill is implemented, we would expect to see a shift, and I think we'll be tracking that, and I hope certain members of the board will also be tracking that.
Thanks. And just also, just to clarify that the reduction in that loss is good for the hospitals because it means they are losing less money. So that makes our hospital system more stable. So we're not only helping people who are struggling to pay their bills, but we're stabilizing the hospital
The
system.
reduction in.
Yeah. Okay. It's interesting how all these gears are interconnected because we're talking about 119, but 721 is going to impact what we were working on in 119. And I'm sure there's more we can do that you'll come back to us with next year.
Thank you for all of your
Yeah.
work on this, and for updating us, and we'll look forward to update whoever is going to be sitting in these chairs next year. So thank you.
Thanks.
We have some members that have to go up and do some things, so I apologize for those waiting for S109. We're gonna start that at 11. So if everyone can be back by 11, that would be